Okay. So
We
good
are
evening.
live.
Yes. Good evening, everybody. I, Dr. Madhura Kelkar, I welcome you all on behalf of the Pune Obstetrics and Gynec Society for our cutting edge webinar series. So this was the brainchild of Dr. Meenu Agarwal ma'am, and we've been conducting these sessions with different societies all over the country every Tuesday afternoon. So this time we are pleased to have it with Baroda and Himmatnagar Society, and we are honored to have dignitaries like Dr. Atul Munshi sir here with us to bless the webinar. So I would request Meenu ma'am to just welcome everybody.
Minu, you're on mute. You're on mute.
Sorry. Hello, everyone, and good evening. Very warm welcome to all of you for this cutting edge webinar. We named it cutting edge webinar because we try to include the latest technology, latest development in OBGYN as well as in endoscopy and ART for everybody. The idea was that this technology or this information should reach to every gynecologist. So that was the idea of starting this particular webinar. And very happy to have all our seniors today, Dr. Munshi sir. So happy to have you with us. Thank you so much for joining, sir, today as the chief guest. And we have our guest of honor, Dr. Subhash Male. I think he will be joining in a bit. We have Dr. Meenakshi madam here, Dr. Rashmi madam here. Then we have Dr. Dinesh Patel here. Dr. Kazi will be joining. Then we have our Dr. Aarti Nimkar, President POGS, current President POGS, and Dr. Meenakshi Deshpande, General Secretary POGS. And we have Dr. Vaishali Chavan, the just with me, the General Secretary POGS, and Dr. Charu Bapai, the Clinical Secretary, and now she's the chairperson of that is, I think, a female study of the breast, female breast, right? So thank you everyone for joining this webinar, and for all the delegates as well. I hope this is useful to all of you, and we have tried to make it in a very nice simplified way, both the lectures. So let's hope that we have a good interchange of the knowledge. So thank you very much again, Munshi sir, Meenakshi madam, Rashmi madam, and all my colleagues, and Archana Dwivedi is here also from birth. So thank you very much, all of you, and welcome, very warm welcome to everyone.
Thank you, ma'am. I would request Dr. Aarti Nimkar ma'am, who's the president of POGS, to say a few words.
Yeah, good afternoon, everyone, and I welcome all the members of the Baroda Society and Himmatnagar Society of Gynec Society, and welcome Dr. Atul Munshi sir as a chief guest, and guest of honor Subhash Malya sir, and Rashmi Banerjee madam, and Meenakshi Patel madam, and everybody. And this is a very good Archana Dwivedi madam, who is the speaker of the second speaker of this cutting edge webinar. And Minu has started, Dr. Minu has started very good program of the cutting edge, and she connect us with the different societies, and we know each other very well through this cutting edge webinar. So welcome all from my side. Thank you very much.
Thank you, Aarti madam.
Thank you, ma'am. So for the formal inauguration, we would like to take blessings of the Almighty and have a small prayer song at the beginning. Thank you. So let us begin the webinar. First of all, I would like to welcome all of you for this session. And we have our chief guests and guest of honors here. And I request Dr. Vaishali Chavan, madam, to introduce our chief guest, Dr. Atul Munshi, sir.
Thank you, Dr. Madhura. And before I introduce sir, I would just like to say words about a cutting edge webinar, which Dr. Meenu Tuesday, 4 to 5 p.m. And this has been carried forward in the next tenure with Dr. Aarti Nimkar as President and Dr. Meenakshi Deshpande, General Secretary of POGS. And this webinar is an endeavor on our part, a quest to spread knowledge to each and every corner of the country. And especially it's important as Dr. Meenu Agarwal, as you know, is standing for the post of Vice President Foxy West Zone. So, she is really, an expert in not only endoscopy, ART and imaging. So this has been an endeavor to, spread this message all over the country. So thank you for Baroda and Himmatnagar societies for joining with us for this webinar. And minute we discussed with Dr. Archana Dwivedi, within 5 minutes, she gave us all the details of all the faculties. And thank you, Archana, especially for this. So it is a proud privilege for me to introduce none other than Dr. Atul Munshi. As we know, he is truly the doyen. He's the doyen for all of us, for entire Foxy, for all the gynecologists everywhere. He's highly academic. And sir, your name is synonymous not only with knowledge and academics, but also you have enlightened all of us Foxians with your beautiful mails and messages and your philosophical messages and quotes. And we have really, really enjoyed that coming from you, sir. Sir is past Senior Vice President Foxy. Sir has been at at many orations, SOGOGs, AOGS, Dr. Das oration at Calcutta, at Navi Mumbai, Indirabai Khare oration at Nagpur, and so on. Sir has been Professor HOD, Gujarat Cancer Society Medical College, Ahmedabad. Sir is also Professor, Head of Unit of BSGH and Srimati, NHL Municipal Medical College, and KM School of PG Medicine, Ahmedabad. And sir has also been past President Ahmedabad Society in 1995 and 96, Chairperson Foxy AIDS Committee in 2002 to 2006, Governing Council Member of ICOG. Sir has been organizing Chairperson of AICOG 2000, Yuva Foxy West Zone 2011. Sir is has received 7 gold medals at MBBS exam, and sir has also been MD examiner. Sir has received so many awards for his papers, for his presentation, and he has delivered more than 100 guest lectures. So, sir, it is a great honor to welcome you for this webinar.
You are muted, sir. Sir, you are muted, sir.
Thank you, Vaishali, for kind words. Good evening to all of you. It's a pleasure to join today for the Pune Obstetric and Gynec Society's renowned webinar series, Cutting Edge. It is nice to have participation from the Bhavnagar and Himmatnagar societies along with this in this evening. First and foremost, I wish to express my heartfelt gratitude to the office bearers of POGS, particularly President Dr. Aarti, Secretary Dr. Meenakshi Ben, and the immediate past President Dr. Meenu Agarwal, whose brainchild is this cutting edge, for extending the invitation to be a part of this esteemed academic endeavor. It is truly an honor to collaborate with my young colleague, Dr. Subhash Malia. Is not there, he must be operating in his place. The topics selected for discussion today are both captivating and insightful. Dr. Meenu will enlighten us on social egg freezing and fertility preservation. I've heard past few cutting edges. She is always there with some new topics every time. While Dr. Archana will share with us the expertise of joyful intrapartum care. I am confident that the presentation will provide fresh perspective and valuable knowledge. I'm also pleased to acknowledge our esteemed chairpersons, Dr. Reshmi, Dr. Meenakshi, Dr. Sarfaraz, and Dr. Dinesh, whose vast experience in the subject will undoubtedly enrich our discussion. As we navigate through today's webinar, I anticipate that we will walk away with a deeper understanding of the subject matter. I extend my best wishes to today's webinar and especially to Minu for his endeavor. She is contesting for the Foxy's Vice Presidency. Thank you very much and wish many, many more future cutting edges. Thank you.
Thank you very much, sir. Thank you for your nice blessing, sir. Thank you for this message. Madhura,
Madhura, you on mute.
Yeah, thank you, sir, for those kind words. I think Dr. Subhash Malia will take another 5 minutes to join. So I think, ma'am, we could just introduce him for everyone.
Yeah,
So I'd
sure.
request Charu madam to introduce Dr. Subhash Malia.
So let him come, then he
Um,
should.
Yeah.
Okay.
We can start with the
Let's
session.
start the first session then. Okay.
So
So let us.
Sincere thanks to Dr. Atul Munshi for sparing his valuable time and blessing this webinar. I did not get a chance to interact with him personally until now, but when I saw his CV slide, it was really so impressive, and I sincerely look forward to meeting him someday very soon. Many conferences coming up in Baroda and in Gujarat area, so I really hope I meet him sometime and take his blessings. Thank you, Dr. Munshi, for your kind words.
Thank you, ma'am. So let us begin the first session, which is going to be by Dr. Meenu Agarwal, madam. For the same, I would like to invite our esteemed chairpersons, Dr. Reshmi Banerjee and Dr. Meenakshi Patel. I request Meenakshi Deshpande, madam, to introduce Dr. Reshmi Banerjee. Meenakshi, madam.
Good afternoon, everybody. From POGS side, as a General Secretary, I would like to welcome all the faculties of Baroda and Ahmedabad societies and all the stalwarts also, especially Dr. Atul Munshi, sir. It's a very pleasure to meet you over here on this webinar. And I would like to introduce Dr. Reshmi Banerjee. She is from Baroda Medical College. She is 25 plus years of clinical practice and a consultant at Zydus Hospitals. We had met before, madam, at Foxy meeting and AICOG years back. Yes. National Chairperson CSR Committee of the Indian Menopause Society. She is Secretary 24-25 of the Baroda Obstetric and Gynec Society. Oh, good. And life member of, yes, IMA, Foxy, ISAR and IMS. She is active member of the Lions Club of Baroda Kalanagri project in charge for female cancer, awareness and adolescent health. She's received a Best Society Award by Indian Menopause Society during the presidential year 22-23 and faculty in many state and national level and menopause conferences organized by many national bodies. Organizing secretary for the National IMS Con 2022 and she's an ardent animal activist. That's a nice piece to hear, madam. Animal lovers are there throughout India and all over the world. And it's a different aspect of social awareness that we need to create. Thank you.
Yeah,
Okay.
thank you, ma'am, for that kind introduction. And now it gives me immense first speaker, Dr. Meenu Agarwal. And I mean, at the first time I saw her on screen, and she came across as a very friendly person. And her CV is equally impressive. She's the immediate past president of the Pune Obstetrics and Gynec Society, elected Secretary General of the International Society of Gynecological Endoscopy, Foxy, Chairperson of the Imaging Foxy Science Committee 2018-2021, Bachelor in Reproductive Endoscopic Surgery, European Board Certified, Post Director for Endoscopy and ERT Training Courses in UAE, and has over 12 publications in international journals. First author of 4 books and authored many chapters. She is also a Bachelor in Reproductive Endoscopic Surgery, European Board certified, and has several awards like India's Greatest Leaders by Asia One, Icons of Health by Times Group, Inspiring Gynecologist of West India by Health World, and Foxy Champion of Foxy Award. And I also wish ma'am the bestest of the luck for her upcoming elections as the West Zone VP of Foxy. And I'm eagerly awaiting to listen to her talk. Thank you.
Thank you, Reshmi madam. I think Dr. Madhura, you have to introduce.
Yes, ma'am, the other chairperson. Yes, ma'am. So I would like to introduce Dr. Meenakshi Patel, who is the other chairperson for the first session. So Meenakshi madam has been the past president of Baroda OBGYN Society. Yes, thank you. Madam has been the president. She got the Best Society Award of SOGOC, sorry, in 2018. She's been the organizing chairperson of SOGOC 2018. 2 years she's been secretary and treasurer in BOGS and the Menopause Society of Vadodara. She's also specialized in, she has fellowship in sonography, in laparoscopic surgery. She has a fellowship in Indo-German Foundation for Laparoscopic Surgery under Dr. Mettler, and also in colposcopy. She's been practicing since November 1990. That is almost 34 years, with 29 years of professional standing till date. She has performed 3,050 vaginal hysterectomies, 5,000 total laparoscopic hysterectomies. She runs Foxy Recognized Hysteroscopy and Laparoscopy Training Center. She's the director of Global Baroda Hospital, which is a 110-bedded hospital. She has conducted many live workshops and paper presentations. She has arranged 20 live workshops in gynecology and obstetrics in her hospital, and she's been a faculty for many workshops as well of operative hysteroscopy. She's presented many papers. Many are published in Foxy journals. She has got the first prize 3 times for paper presentations, one in ISOPAR and one in SOGOC, one in Baroda Society annual day. She has many publications in many international journals, international and national journals. So welcome, ma'am. I'm amazed to see the number of surgeries you have performed and the number of years you have experience. So we are honored to have you for the with us for the webinar. Thank you, ma'am. With that, I think we can start with the first session. Meenakshi madam, would you like to say a few words before
Thank
starting?
you, Madhurika madam, for the kind words and my special introduction. My best wishes to Dr. Mini. In advance, we are saying congratulations for winning, madam. And now, floor is yours, please.
Thank you so much. Thank you, Meenakshi madam. So, with the best Munshi sir, and from Ahmedabad and from Baroda and Himmatnagar societies, so and POGS society, I'm very happy to present my first presentation, which is on fertility preservation. I'm sorry. One moment. Yeah. Okay. I hope my slide is visible.
Yes, ma'am.
Thank you. So, good evening, everyone, once again. So, fertility preservation. Now, it was a relatively new terminology a few years ago. However, now everybody is talking about fertility preservation, and it is also the need of the hour that we need to preserve fertility. In some cases, a social need, and in some cases, it could be a medical or a scientific reason that we need to preserve fertility. So we talk about social egg freezing. We talk about egg freezing in something like cancers, endometriosis. And there is something new. Last month we conducted a program on transgenders. So where there is a kind of a sex change, or, the person is put on various hormones. So there also a fertility preservation, because if it is a female getting converted to male, the ovaries will, either she will go in for a surgery for removal of the ovaries. So there the fertility preservation can also be one of the reasons where the fertility can be preserved, although I have no personal experience in fertility preservation in transgenders. Then when we talk about social egg freezing, now what is social egg freezing? Is it something which should be advised? Is it something which should be encouraged? Or is it something which is a need of the hour? Even if we don't encourage it, it is there, and if need be, it should be used. Though there was a time when Apple and Facebook, the company CEO said, okay, we do not want to let our lady employees take leave and you can freeze your eggs and continue working, which was not a very right message which was given to the young girls who were working and who wanted to take leave. However, there is another reason where the eggs some lady has frozen, and that is equalizing the gender. See, what is happening is the reproductive age of the girl or the woman is the career age for the men. So sometimes because the women are into reproductive path, so they kind of lag behind. So for that reason, they delay the pregnancy. Because they are delaying the pregnancy, they are okay career wise, but at some point of time they realize, oh my God, my ovarian reserve is very low and now I want to have a child. So to have it both ways, there are options where we should look at the various options in various circumstances. We have to understand that time is not our friend. That वक्त मूवी की वक्त सबका बदल जाता है. कुछ जब यंग रहते हैं तो सबको लगता है everything is hunky dory, I can achieve everything in the world. But when suddenly they realize the egg reserve is low and she's not able to conceive, that is when it can hit a young beautiful girl very hard. So women is in conflict. You know, she wants to have a career and she also wants to have a child. They don't want to give up the reproduction because they want to have the career. And there are women who do not want to give up their careers because they want to have a child first. Or sometimes they don't get the right partner. Okay, she's the girl 34, 35, but ladka matlab the one somebody who she likes, she's not finding the right boy. So she should not get married just to have children. She should find the right person. Or sometimes she's married, but something doesn't work out between the two of them. She's divorced, and again she's looking for Mr. Right. However, her fertility is declining by the hour, by the day, by the month, by the year. So time is running out between the ages of 25 and 35. Then when we look at this particular graph, this is the graph which came from Europe. And you can see here that, 1 minute. Okay, so we can see here in 1970s, older than 32 and single, this 10% of women. Here in 1990, older than 32 and single, it went to up to 20%. And in 2009, older than 32 and single, it went up to almost 50%. And the recent data, I don't have I was looking, trying to get the data recent to 2024, but I'm sure it must be much more than what it was in 2009. So the women are becoming older by the time they want to have their first child. So you can see here also the birth of the first child age has gone up. And of course, in India, birth of the second child, third child, not many couples are opting for. So fertility is decreasing with age and more women are delaying their childbearing. So this is how the percentage of the fertility goes down. And the and as the see, agar egg freeze kiya, it is not only that you have frozen the egg to be used later, it is also the miscarriage rate. So if a woman who's conceiving at the age of 37 years with the egg of 37 years at that time, the chances of her having an early pregnancy loss are much higher as compared to if she conceives with their own egg frozen at the age of 28 or 29, because the aneuploidy rate is much lower. So there are also the medical benefits. So we understand that as the age advances, the risk of aneuploidy goes up. So that is also one of the reason why the egg should be frozen, if at all, at a younger age rather than at an older age. So what we have to look at now, we see here, the man equality, the gender equality, even nature has not given a gender equality. So man can become father, he can become a father even at age of 45, 50, 55 also, no problem. But for a woman, it becomes difficult to conceive once she crosses a certain age. एंड बहुत बार ऐसा होता है पेशेंट्स कमेंट से कि नहीं आईवीएफ विल बी द लास्ट ऑप्शन, नहीं हुआ प्रेगनेंसी तो विल गो फॉर आईवीएफ. बट वी मस्ट टेल आवर पेशेंट दैट आईवीएफ शुड बी डन एट द राइट एज, at the right time, because even ART or IVF, as it is generally people call it, it cannot overcome age. So when we look at the fertility, at the positivity with pregnancy, with IVF, the pregnancy below 35 years of age, the pregnancy, the positive results are much better as compared to the over 35 years of age. Now, why suddenly we are talking about oocyte freezing? Why? Because now we have a technical breakthrough in terms of vitrification. Earlier, we had slow freezing. So suppose I would freeze 10 eggs. When I would go to recover, because it was slow freezing, I would only get 5, 6, or 7 eggs. However, with vitrification, the advanced technology where you are jumping from whatever normal temperature to suddenly to minus 140, so you are suddenly jumping into cold without getting in between slow freezing. No ice crystals are forming, so the oocyte recovery is almost 90 to 100%. So today if I freeze 10 eggs for a girl, when she comes back after 2 years or 5 years, when I harvest, when I thaw, when I warm those thawed eggs, I would get almost 90%, 9, or maybe sometimes 100% oocyte retrieval, the harvesting. So that is very, very important for us to understand. Also, when we do the oocyte vitrification, it does not increase the risk of any aneuploidy. The infant outcomes are same as you would expect in any other IVF cycle or in a spontaneous cycle. So ASRM and various other organizations are talking to the insurance companies, telling them that don't consider egg freezing as experimental, because in Western countries, the IVF is covered under insurance, but they are not wanting to cover egg freezing under insurance, because then, it is a kind of a Pandora box that everybody will want to freeze their eggs, and very difficult for them to then take care of the finances. So whether to freeze the egg or to freeze the embryo, if a woman is married, she has a steady partner, it is good idea to freeze the embryos. If she is single, then of course freeze the eggs. Now again, lot of debate is going on. They say कि अगर आपने 10 eggs freeze किए हैं, when you recover, you are getting 10 eggs again. You can then fertilize with the with the husband's sperm after thawing. So why freeze the embryos? Because today with vitrification, we don't see any distinct advantage of freezing the embryos. So that is a debate that suppose they don't get along, suppose they separate, suppose something happens to the husband, all those things, the debates keep on. I think that this is science. There are debates and there are always something or the other where we keep changing our thinking. Again, sometimes we see young girl, 21, 22, her AMH is only 1.2. You see her elder sister is say 24, and her ovarian reserve is gone. So they sometimes there is mosaic Turner syndromes. So look for their karyotypings. If their karyotyping is showing X0, they are going to deplete their eggs very, very soon. So then go for the egg freezing for these particular girls. So again, as I said, when we talk about social egg freezing, who should freeze the eggs and how many eggs should be frozen? So they say ki you should, if you have 6 eggs frozen at the age of 25, you would have 40% chance of a live birth. If you had 6 eggs frozen at the age of 35, you would have 23% chance of live birth. So we at our center generally go for 2 cycles. If we get in one cycle 6 eggs, we go for stimulation for the next cycle, and we try and freeze at least 10 oocytes for the lady. So 10 to 15 as per the guidelines. And also if she has a history of infertility, if there is a history of prior IVF cycle, now she doesn't want to have a child, but she has a history. So in that case, again, you should, or they are not together anymore and she wants to freeze her eggs. So all those things should be kept in mind. Then again, we have people there are so many people who freeze their eggs and use their eggs, but they don't come out. Dinah Hayden was one person who actually came out, and she said that I froze my eggs and I had children from my frozen thawed eggs at the age of 37. So it was very nicely done by Dr. Rishikesh Pai and Nandita Palshitgar, and she came out in open and she said, yes, I froze my eggs and I used them. So that is one of the reasons why, sometimes all these, film actresses, we see she had a child at 37, at 38, and the young girls think it is all right. You can wait. They can have a child. We can also have a child at a later date. However, they do not know that maybe they are using some scientific things that they are able to freeze their eggs, and then they are using those frozen eggs. Again, Jennifer Aniston again also came out and saying that she froze her eggs because she wanted to beat the biological clock. Now, this is one side of the story. What is the other side of the story? Now, suppose we have this young girl, 33 years old. She has bilateral endometriomas, 4 centimeters, 5 centimeters. She's sexually active, severe dysmenorrhea, dyspareunia, AMH is 2.9. What next to do for her? I'm sure, I don't know if Subhash has already joined. I'm sure the laparoscopic surgeon here would say, yes, she needs surgery. She has pain. She has endometriosis. However, keeping in mind her age and her AMH is decent, it is not very low. I think this is the girl we need to counsel her for egg freezing, because the moment you operate on her, a year down the line, she will come back with her AMH of 1.1, 1.2. She's now unmarried. She could still be unmarried a year later. So that thing has to be kept in mind. And that is how the fertility preservation in endometriosis, very, very important, whether she are going in for a surgery. Even if we are not going in for a surgery and she has endometriosis, she may not be having pain. We want to put her on medical management for endometriosis. However, it is a good idea to talk to them, to tell them about the egg freezing. And most of my friends, their daughters, they have frozen their eggs with me. And not that they have to use those eggs. They can still try for a spontaneous conception if they find the right partner and they go ahead. But this is like a backup. And whenever we are freezing the eggs, a proper thorough counseling that this is not a 100% backup. There is still a possibility that you may not conceive with these frozen eggs. So don't take them for granted. Try naturally for a few months. If you conceive, if you get married at the right time, maybe there's still some good ovarian reserve, try naturally. Only if you don't conceive with the natural thing, you can go for the backup option. Or if they get married very late, she's 42, she froze her eggs at the age of 31, then it makes sense to use the frozen eggs. So when to freeze the eggs, when to freeze the embryos, when to freeze the ovarian tissue can also be frozen. So eggs can be frozen for everyone. Okay. Embryos can be frozen for a married couple. So husband, wife, for some reason, either she does not want to have a child now. So we can freeze the embryos, or there is some other reason why we need to freeze. Ovarian tissue is generally for children. suppose some child is got diagnosed with some kind of a cancer, you need to put her on chemotherapy. Now you can't stimulate the ovaries. She's 12 years or she's 9 years old or 7 years old. So there we can do the freezing of the ovarian tissue. Even for men, I sometimes get men where they had some kind of a cancer and he took chemotherapy. However, just a very small thing, he could have given a semen sample and that could have been frozen, which was somehow got missed, because in oncology, they are thinking about life and death. So they are not thinking about fertility so much. So that is again important. I think that, all these onco centers should be aware of onco fertility and onco fertility preservations. Now, many societies have come up which are named as onco fertility association. Then, of course, as I said, that sometimes a woman has to undergo she is diagnosed with malignancy. Now, the moment she is diagnosed with a malignancy, the first thing is told, first get rid of the malignancy. I do not want to have a child. I want to, the parent, everybody says, we want her, we don't want the children. But a thorough, informed counseling is very, very important, because later on, they do get depressed. They feel that why were we not told that you could preserve, you could freeze your eggs, you could freeze the semen. So all that thing should be informed, thing should be told to them, and then of course they can decide whether they want to go ahead for the freezing or for the they don't want to go for the freezing. So young cancer patient, we do FSH, AMH, antral follicle count. Now very important is, suppose usko aaj diagnose hua that she's got a cancer, any kind of a cancer. Earlier we had to wait for her cycles to come and then start stimulation from day 2, wait for about 10 to 12 days, harvest the aspirate the oocytes, and then go for the chemotherapy. Now with the more and more understanding of the endocrinology, we know that there are cycles. So random start. So today, suppose she's diagnosed, today could be her day 21, could be her day 7. Any day of the cycle, we can start the stimulation and we can go for the freezing of the eggs. And that knowledge should be available to each and every one of us, that we can start, random stimulation can be started and the eggs can be, or the embryos can be frozen. So both embryo and oocytes can be frozen. There is also a possibility that we can harvest the immature oocytes, freeze them, or then we can mature them in vitro. However, that is not giving very good results. Ovarian tissue cryopreservation, whole ovary preservation is also possible. And sometimes just a simple procedure that you take the ovaries out of the pelvis. Suppose she has to go for a radiotherapy, and then we cover them with titanium clips to mark how much area to be exposed to the radiotherapy, and that can also be done for these patients who are going in for a cancer treatment in terms of pelvic radiation. So we understand, of course, as I said, that oocyte vitrification is a viable option for fertility preservation. Sometimes you may need multiple cycles, especially in poor. See, for me, most of my patients, they come at the age of 34, 35, 36. That now I want to preserve my, freeze my eggs. That is a little late. So at that time, I need to do 2 or 3 cycles for them. And then I can say, okay, I have got 10 eggs for you frozen, and then you can go for the thawing of these eggs and fertilization with the sperm when you find the right partner. So, autologous spanking in cancers, in cytotoxic chemotherapy, in conditions like Turner's, mosaic Turner, electively like a social egg freezing, and also for donor egg banks. Now there is this new ART bill is not allowing the freezing, but there was a time when we had a lot of donor egg banks where they would freeze the eggs from the egg donors and then they would supply to the various ART centers. So this possibility at the moment, it is not there. So when we are freezing the eggs, this is not what we are looking at. We do not want the next generation 60-year-old lady getting conceiving, but we are looking at the positive aspect of the egg freezing where suppose she wants to conceive after 5 years, she's 34 now, 35 now, at the age of 40 or 41, she should not go in for a donor egg. She can go for her own egg, provided it was frozen in time. So thank you very much. And I request every one of you to support me for the post of Vice President, Foxy West Zone, election year 2024. And thank you once again for giving me for the kind attention. Thank you so much.
Thank you, madam, for such a wonderful, nice elaboration regarding the social egg freezing and preservation of the fertility when and how. Ideally, 10 to 15 eggs should be frozen if a person wants, and it is most useful in cases of cancer, chemotherapy, radiotherapy patients, myelodysplastic syndromes, premature ovarian failures, germ cell degeneration, Turner's mosaicism, trisomy, X fragile syndrome. They will benefited with these things. And you have also mentioned regarding the ovarian tissue preservation as well as the premature oocytes preservation also. Thank you for a wonderful elaboration. And we also came to know new things because we are not IVF consultants. So we also came to know the different things.
Thank you, Meenakshi. Also, one thing is, suppose somebody wants to do ovarian tissue cryopreservation, the strips of the cortex can be taken, put in the culture media, and then sent it to the another lab. So that is a possibility. It does not have to be done at the ART center. It can be done at another center and then can be sent to an ART center who are specialized in egg freezing and ovarian tissue freezing.
Yeah. One question I will like to ask you, madam.
Sure, madam.
Regarding these frozen eggs, how long you can freeze these eggs and use these eggs at least for 5 years, 10 years, 15 years? How long you can preserve these eggs?
Yes, madam, you can, they are frozen in time. So you can take them out at any time. However, as per the ART bill, the lady can go in for an IVF only until the age of 50 years. So after that, we cannot use it for her, even her own eggs. So that is as per the ART bill. But otherwise, suppose she freezes at the age of 32 and she wants to conceive at the age of 47, she can use it. They are frozen in time, madam. No
One thing, another question I will like to ask, whether this girl, instead of going her eggs frozen at the age of 35, can it be possible she can go for earlier so that the better eggs she will get it at the age of 20 to 25?
Madam, ideal age as per the international guidelines is 29. So between 29 and 32 is the ideal age for preserving the eggs. But क्या होता है, girls, they don't realize they are in their youth, मतलब वो अपने में रहते हैं, certain age 34 cross हुआ, 35 cross हुआ, then they realize, oh my god, now I'm not finding the right partner, so I should freeze my eggs. So that is a little bit of a thing that they go for late preservation. But you are right, it should be done earlier. Done is better for us.
And regarding the endometriosis also, which one you will prefer, whether to go for the surgery first or whether to freeze the eggs first and then go for the surgery?
I would go for the egg freezing first, madam, and then the.
Thank you, madam.
Minimum, I have one question. What is the youngest age reported in literature for both semen and egg freezing and ovarian tissue freezing? Like, because since childhood cancers are also on the rise so much.
See, I will not be able to tell the earliest age, but even a young girl or a young boy, the testicular tissue and the ovarian tissue both can be frozen. And
see, we see even patients undergoing going for chemo, radio, even at the age of 15, 16, 17 years. So for such young people, can they freeze their gametes for such young children?
In 16, 17, they can be stimulated and the gametes can be frozen. But if it is younger than that, or the boy is not able to give the sample, 16-year-old boy.
Yeah, that's what. So because why I'm telling the hospital where I'm working in, we have a patient of ALL. So he was first diagnosed at the age of 16 when the Right now he's about 32. He was first diagnosed at the age of 16. He underwent chemo and all. And then he was in remission. He had a relapse when he was at the age of 27. He got married when he was 24. They did not have a child. Then at 27, he had a relapse. At that time, he thought about semen freezing, but by that time, everything was gone. He was azoospermic. So he was very sad. So he said, ma'am, could I have frozen at the age of when I was 16? That is almost 15, 17 years back. At that time, semen freezing was, available. But like at the age of 15 or 16 or 17, can the boy freeze? That is what my question was.
Most of the boys are able to masturbate and give the sample.
Yeah.
How they are not able to give it, in that case, a testicular tissue freezing can be done.
Tissue can be frozen. So for girls and boys both, or even, girls have one certain menarche, they can.
Yes, for girls, ovarian
Theoretical.
quite standardized. Vertical cuts on the cortex with scissors. And then again, like a crossword, we give cuts and then just remove the strips. And once you have taken the strips out, just keep a pressure with the gauze for a bit. It stops. If there is a little oozing, just touch and go with the cautery. That is fine. And then those strips are placed inside the abdominal cavity into the culture media, and then the culture then they are pulled out and frozen. So it's quite simplified for laparoscopic surgeons.
Thanks, ma'am, for that enlightening talk.
Thank you, madam. Thank you.
Best of luck again.
Thank you, madam. Welcome, Dr. Kazi, sir.
Hello, ma'am. How are you?
Thank you.
I was just listening quietly and I was stunned as usual with your talk.
Today, Kazi has got an update, madam, and it was very nice. Kazi, till I share my screen, would you like to share the incidents? 8 years wala jo aapne aaj share kiya.
Hello.
Yeah, ma'am. So we will start the second session. Meenu ma'am, that was a great talk. So for the second session, where Dr. Archana Dwivedi madam will be talking about intrapartum care, I would like to invite our chairpersons, Dr. Dinesh Patel and Dr. Sarfaraz Kazi. I request Charu ma'am to introduce Dinesh Patel, sir.
Thank you so much, Dr. Madhura. Indeed, a pleasure to be sharing virtual space with so many friends, right from Dr. Archana, Meenakshi, Dr. Sarfaraz. And today I come to know about Dr. Dinesh Patel, who has been the past president of the Himmatnagar OB-GYN Society. He's a gynecologist, he's a laparoscopic surgeon, and he's an IVF specialist. Sir, hats off to you for this, because the current generation, it finds it so difficult to manage all these things. They either want to be only fertility specialists or only laparoscopic surgeons. Very few people want to do deliveries, but you have managed to do more than 30,000 deliveries, more than 10,000 lap surgeries, and have helped more than 3,500 infertile couples. So this is a great achievement, and we bow to you. So currently, you are the director and consultant obstetrician at Vardhan Women's Hospital. And another fantastic thing that I just read in his CV was that he's been the president of Himmatnagar OB-GYN Society right since 1994 until now. Sir, hats off to your patience, hats off to your organizational skills, and hats off to your ability to look after this organization for so many years. You are indeed an icon in this field, and we couldn't have asked for a better person than you to be an esteemed judge. Thank you for your presence, Dr. Dinesh.
Sir, unmute yourself.
So there is
Thank you, madam, for your kind words.
We'll go one slide back for introduction of Dr. Kazi.
Yeah. I request Vaishali ma'am to introduce Dr. Kazi.
Yeah, so it's an honor for me to introduce Dr. Kazi. And sir, it was a privilege to interact with you 2 days ago and while planning of this webinar. And as you know, sir is president of Himmatnagar OB-GYN Society, and he's also director of Navjivan Women's Hospital, Himmatnagar. And he's a gynecologist and endoscopic surgeon, infertility specialist, and since more than 20 years. Plus, he has a lot of experience in running high-risk pregnancy unit. So, sir, you are actually doing everything, right, from obstetrics, endoscopy, infertility. So, truly impressive. And he has also had advanced training in gynec oncology at Ahmedabad, fellowship in reproductive medicine. And sir is also member of Society of Fetal Medicine, organizing vice chair of SOGOG, president of Himmatnagar right now, and local joint secretary of SOGOG, also state coordinator for sexual health and STI committee, FOXY 2024-25. So we would like to give you a warm welcome and we request you to chair the session.
It's really an honor, Vaishali, and it's very nice to see you again after AMOX. And as usual, you and Minu ma'am are looking still gorgeous.
Thank you.
Thank you.
And thank you very much, Minu ma'am, and all Pune Society. It's my pleasure to be chairing this session. And my job is to introduce Dr. Archana ma'am. Everybody knows her very well. She is right now the president of BOGS. She is also a founder president of MSV. She is a secretary. She was a secretary of WDW-IMA for 2020 and 2022. And she is also practicing since last 20 years in Baroda. Her key interests of subjects are high-risk pregnancy, laparoscopy, vaginal surgeries. Specifically, she is a master in NDVH of any complicated uterus she can remove by vagina. She was also a faculty for adolescent counseling and menstrual hygiene awareness and anemia eradication for Vadodara and periphery. She is very well-known social service. She is doing very well-known in social service with Sneh Foundation, I think, Sneh and Swadesh. And she got many awards like Jagdishwari Mishra Award in ISOPAP, Gujarat Gynec Excellence Award. And in her tenure,
I think, Sarfraz, that is more than enough. I think I'm standing with all of the people.
In her tenure, he got, every time he got Best Society Award from FOXY. And Baroda, when she is the president, no one can go for the Best Society Award.
Thank you so much, Kadi. Thank you. That was so humble of you.
Apart from this, she is extraordinary, talented, very dynamic, and she is also contesting this time. So we all are with you, ma'am. And now floor is yours.
Thank you so much, Dr. Kazi. Indeed, it was a very so humble and so kind of you for introducing me so nicely. I felt really overwhelmed. So first of all, I thank POGS Society, my dear friends, Vaishali, Charu, and obviously Minu ma'am. The rose picture is still fresh in my mind. And sharing the dais with Dr. Sarfraz Kazi, and as you rightly said, Charu, King, Dr. Dinesh sir, is an honor to me. And hereby I present you intrapartum care for joyful motherhood. So madam had a brainstorming good means inputs on how to increase the fertility. And once you are fertile, you have conceived the baby, your interpartum care is very important for all the obstetricians who are practicing over here. So this concept is actually resting on three important pillars where the patient is complaining of pain, and we have to ensure the adequate uterine contractions, and there should be a very close monitoring of the labor events, that is known as maintaining a partogram. Active management of labor, and to relieve her from the pain, we need to have a proper use of antispasmodics and analgesics so that at least she can also enjoy with us the delivering of the baby. Now, we have to think about active management of labor, which was a concept advanced by Irish School in 1973, where the reports on advantage of active management of labor, which resulted in short labor and improved obstetric outcome with a lower cesarean rate, was seen. And this active management is very well required to prevent the infection, exhaustion of the mother, dissolution in the mother, ketosis, fetal distress, and important point is to prevent the dehydration. We all know about this beautiful chart I see over here, that is the partogram, which is a composite graphical record of prolonged labor, which was coined by WHO in 1994 and modified in 2000 to start with the cervical dilatation of 4 centimeters. And it is a very important diagram where mostly a nomogram lies on the left side of it. Whenever we are seeing that the time has elapsed more and the graph is shifting toward the right side, that means the alert zone has started and can serve as an early warning sign. And we need to intervene, augment, and see what is the delay, and henceforth manage it promptly.
So important thing is that we need to have a proper selection of the patient where we have no identifiable medical or obstetric complications which are present, primary gravida with singleton pregnancy with cephalic presentation and with spontaneous onset of labor, and gestational maturity at the term, which is 37 to 41 weeks. On admission, her non-stress test, which is done, has to be reactive, and active phase of labor with cervical dilatation 4 centimeter and 50% efface. This is a very apt patient who has to be shifted into the labor room and partogram has to be initiated. The selection criteria again is a low risk patient where the presence of anesthetist and neonatologist is an important part. Consent is very important and it should be primary or multi more than 38 weeks of gestation, and during the active phase of labor, we start monitoring that. Patients who are not to be considered for intrapartum care are to be excluded as high-risk cases or with comorbidities like diabetes, polyhydramnios, oligohydramnios, or CPD, malpresentation, or there is a pre-labor rupture of membranes, and the patients of preeclampsia where the postpartum or the intrapartum care becomes a different chapter and cannot be considered as a normal partogram patients. So the medication protocol for intrapartum care begins only after the patient enters the active phase of labor where the cervical dilatation is 3 centimeter or more and effacement is almost more than 50%. Contractions are coming regularly, 3 contractions per minute, and last at least 35 to 45 seconds. Head is to be engaged and there should be no clinical suspicion of cephalopelvic disproportion. Patient should be showing the draining or the show sign. So the starting point is very, very important, which was defined by WHO and the basis of clinical evaluation. Cervical dilatation more than 3 or 4 centimeters is the point where we need to start. The medications which we have been using in the intrapartum care as per protocol is a combo of the drug which needs to consolidate the need for effective pain relief coupled with antispasmodic drugs. Local or the labor analgesia is one part of it. And also it helps in cervical softening, yielding and dilatation to the moderate driving forces in order to facilitate the head passing through the vaginal canal. The advantage is that it provides a benefit of drug synergism while at the same time restricting the doses of drugs to the minimal amount to commensurate with achieving progressive labor. And at the same time, the mother is also safeguarded from the complications and we have a good fetal outcome and there is no major drug adverse effect too. Talking again about the intrapartum care protocol and step forward, we have to start the IV infusion line with 5 per Springer RL solution at the rate of about say 20 to 30 drops per minute. We have to ensure that the pains are optimal, that is almost 3 to 5 sustained pains per 10 minutes. And if necessary, if required, we can add 2 units of oxytocin to augment or give a tablet of Primiprost orally every hour to ensure optimal pains resulting in progressive labor. Nowadays, we are also using 25 micrograms of misoprostol. Dilute 1 ampule of 30 milligram of Fortwin with a diluent like a normal saline or distilled water, and similarly dilute ampule of diazepam in 10 ml of diluent. Administer 1/5, that is a dose of 6 milligram of pentazocine and 2 milligram of diazepam slowly in bolus from the tubing to the infusion line, and start an IV infusion line with the RL about 20 drops per minute. Ensure that the pains are optimal, and if necessary, we have already added oxytocin and we are ensuring that there's early progress of the labor and optimal pains are coming, and we are already having a partogram charting in these patients. So once we have diluted, we have given this administration of diazepam to the tubing of line. We have to observe the progress of labor, and maternal fetal parameters have to be monitored every hourly, like the BP, pulse rate, temperature of the mother, signs of dehydration, the cervical dilatation, and along with that, the descent of fetal head is there or not. It has to be documented periodically on the partogram. And once the advanced labor sets in, the fetal head is already pressing down the pelvic floor, the patient starts complaining of severe pain or the bearing down sensation. This is the time that cervix is already 7 to 8 centimeter dilated, and the time to administer ketamine if required in order to console the patient. And Important point is here, if we are using anesthesia during labor, epidural anesthesia or the obstetric anesthesia, the places which cannot provide epidural anesthesia, we can use tramadol or the contramol as a centrally acting non-opioid analgesic, which has been very effectively used as a labor analgesic. Sometimes we have to administer Paranorm or MSET during this time to avoid unnecessary vomiting episodes. Ketamine and dissociative anesthetics is gaining popularity as it provides excellent pain relief and patient satisfaction. So her cooperation is more. Important thing here is that the level of analgesia which we are providing to our patient has to go through these scale. If there is no pain relief or mild pain relief or a moderate pain relief, and we have to categorize the excellent pain relief. So if we have to talk about the clinical evidence, how the things go, there were two groups who were studied, and the vaginal deliveries, unassisted delivery, low forceps, Ventouse and LSCS, and the mean duration of active phase of labor was calculated, along with mean cervical dilatation, mean duration of second stage, and the pain relief, where we had seen that the patient in which we had a program labor and the control labor, you can see the parameters are more better if we talk about the programmed labor. Also compared to the perinatal ROS, we are into a win-win situation if we give a good intrapartum care under the programmed or the protocol guidance. So important thing is that we have to follow the protocol, but the only thing is that the patient selection should be very proper. And we are aiming to the rate of cervical dilatation in active phase, that is, in the cases we had almost 1.72 centimeter, that is augmented stage. And control, where it is led to the spontaneous, we see the dilatation is comparatively at a lower rate. So the faster rate was observed when it was an induced protocol, and also the duration of stages of labor we have minimized when the proper protocol was used. So there is a statistically difficult, a very good situation in the protocol programmed monitoring of the intrapartum phase. Pain relief was also very much good if we see in the study group as compared to the control groups. Also, when we see in the terms of the complications of neonatal and the maternal complications, we see that there was a win-win situation where we have observed the monitoring with the partogram using the protocol-based drugs and had a better even the neonatal outcome. So coming to summarizing to the results, the rate of cervical dilatation was improved. The duration of active phase of labor was significantly reduced, and also the second stage of labor was cut off, and majority of the patients delivered vaginally, almost more than 90% compared to 88% in the control groups, and had a better pain relief, and which was a very statistically significant data, and had less side effects of drug related if we have to compare, even 12 hours after the postpartum phase, and there was no significant neonatal complication seen. So this funnel plot of comparison, again, you can see that we were into a better position when we took antispasmodic versus the control where nothing was used. And the outcomes were definitely better when we were using in the first stage of labor, with a 95% of confidence level of the was seen, and the mother was being more cooperative in the process of labor. As you can see here, antispasmodic versus control, if we see the a study, again, the duration of the third stage, total duration of labor, and the outcomes, if we compare, and also the rate of cervical dilatation, everything was into a short, better way. A rapid progress was seen, less exhaustion of the mother, with a very good neonatal outcome also. So I think when we are using this protocol, it is always a very good thing and should be used. But the only thing is that you should have a proper monitoring and proper partogram, charting of the patient, and your paramedic staff should be trained, or the medical officer or you yourself monitoring should be well aware of the signs and the symptoms which are seen while the monitoring of the patient. This is a very effective drug, the valentamate bromide. Commonly we call it as epidosin, which was used in many, we are also rampantly using, and it helps in the active phase for the cervical dilatation where the delivery was occurred in almost 20 minutes. if we compare to the patients who do not receive the apidocin. So important thing is that it is a significantly shortens the second stage of labor, and it's a very promising drug. When it is used along with the Contromol or the Tramadol, the rapid progression of labor was there. I mean, the shorter duration, the cut down of the second stage of labor. So it is a very good thing if we be introduced into a labor management protocol. Also compared to the side effects were statistically significant if we compare to the placebo and the active group where we were giving the apidocin. So I think that was drug reaction with hyoscine and valentamide for the cervical dilatation. If there was a comparison, there was no statistically significant much of the difference found when we compared, but the stage were shortened and we had a very good cervical dilatation with the use of apidocin or the valentamide at the right time in the active stage with the proper dilatation of the cervix. Again, we compared Dotaverine, which we are again using in our day-to-day practice. And this group, when we compared with the Group B, where the apidocin or the valentamide was used, headache and cervical tear are less compared to the Dotaverine patients. This is just a trial which was performed. And if we have to see why we are using the intrapartum care and why we have named it as a joyful care, because we want to have a good outcome in terms of the maternal and fetal complications. So if there are shorter labors with substantial pain relief, significant amnesia of painful events of labor, and average blood loss was also less, duration of all three stages were markedly reduced, obstetric management was more simplified, and there was a lowering incidence of operatic deliveries, and neonatal morbidities was similar to the control group. So all these things put into a same basket, in one basket, we are indeed having a joyful form of dealing with the maternal outcome, and intrapartum care here gives us a better future and better promising role of obstetrician, a happy mother and a happy fetus. That is what we are ensuring by giving this type of care. So before I conclude, we have got Dr. Dinesh Patel sir over here with a vast experience of so many obstetric. So you can unmute yourself. I would like everybody to share a few cases where you have been having the protocol-based intrapartum care, and what was your experience, sir?
Thank you, madam, for excellent presentation. And this is basically everybody knows that obstetrics is a natural process, parturition. And most of the time our colleagues are saying that if you will not do anything, then it is going to be better as per nature's call. But being an obstetrician, we have to be there and we have to avoid all possible complications which are occurring naturally. And for that, an obstetrician should be taken it as an art and with a proper protocol. Everything you have mentioned in a proper way. If you are alert enough with a proper way and proper protocol, then obstetric result will be excellent all the time. And in today's area, most of the obstetric gynecologists are interested in infertility, endoscopy, and superficiality practice. Nobody is interested in obstetrics. But if you will do a obstetric in a proper way and considering is an art, then definitely it's a service to the society. And even I can say you can become a king in your area if you will do the proper obstetric work.
Yeah,
Thank you, madam. Thank you for
perfectly said, sir. So I think, Meenu, madam, I'm going back into my residency days where we had almost 12 to 14 patients at the labor night, and we were monitoring aggressively. I think we had oxytocin and methergine to our rescue. So oxytocin monitoring, and we delivered efficiently, even face presentations that time, breech also we used to deliver. So I think a vigilant obstetrician or the labor monitoring paramedic staff, which is properly trained with proper use of drug protocols, would definitely give us a very good results. Dr. Munshi Sahib, what do you want to add into that? I would like to have your experience on that. Sir, please unmute yourself. Thanks. Okay, Dr. Kazi, can you add something to that?
Yes, ma'am. According to me, first of all, it was really an excellent presentation by you, as usual. Every time you are rocking the stage. And the thing is, according to me, obstetric practice is the mother of our field. If you are expert in obstetrics, you can be a super specialist in any field. So the dare and the risk-taking behavior, what you get from the obstetric, you will not get from any other field. We people are here only in Himmatnagar. Me and Dr. Dinesh Patel, we both are using penless delivery system since many years.
So I think epidural analgesia is a very good thing.
Yes.
Also is that a proper monitoring system should be incorporated in your labor room, and the patient has to be counseled well. But sometimes what I feel, Meenu ma'am and Vaishali and Charu, that if we, as Dr. Dinesh said, if we leave the patient to deliver normally without giving this epidural, we have a better outcome in terms of ventouse or forceps or increased cesarean rates. The only thing is that the painless delivery, if we give a proper analgesia, along with, I think, tramadol is a very good drug which is available, and epidocin and rotavirine proper use. I think we are using epidocins rampantly nowadays. And with misoprostol also to our rescue with for the induction protocol, if we use 25 micrograms, I think we are heading towards a safe labor, especially third stage of labor. And yes, Munshi sir is back. Can we have a word from you, sir?
It's whether I'm audible.
Yes, sir, you are audible, but we cannot see
Hello?
you. Audible. Audible, sir, audible.
That's right. So whatever you said is completely right. We have seen cases from all normal deliveries to all cesarean sections. So this is rightly think that if you do it properly, as Himmatnagar people have rightly said, Dr. Kazi and Dr. If you do it properly, you can always do a normal ratio of about 60-70% normal deliveries, or at least vaginal deliveries, and 20 to 30% of cesarean section. The ratio is unfortunately been shifting from one side to another side. There are various reasons. I don't say no, it's not there. For a premature child, for an abnormal child, for abnormal uterus and other thing, you might have to do it. But as you rightly said, your presentation was quite good, and you program labor is always better. Ultimately, what we want is a healthy child in possession of a healthy mother. Thank you.
Yeah, thank you, sir. And the other thing which I would like to just put a question forward to everybody. Now we have got more elderly primigravidas. So there are so many things. If they are not exercising, the pelvic floor is not so strengthened. There are so many other factors also, but in these cases also, if we counsel them properly, we can subject them to a program protocol of labor. And here, I mean, epidural analgesia probably would give us a good result at the right time. Any say on that, Dr. Charu, Dr. Meenu ma'am?
I always feel, if the patient does not always say, Madam, I want you at the time of my delivery, I want you at the time of my delivery, then sometimes you try to hasten the delivery. Otherwise, you leave the patient on her own, and sometimes can dilate and deliver nicely, even without your presence. So that counseling of the patient, I feel, is very, very important. That it is not important to have your doctor to hold the baby or to catch the baby, rather than give you time to deliver whenever your body is ready to expel. So that is one thing I would like to say. Yes.
Yeah, so what we've been taught, watchful expectancy and least interference. So
One more thing.
Yes, sir. Yes.
Yeah, one more thing I want to add in a teaching institute. As we came to know that the outlet forceps and all these instrumental deliveries like absolute for the new gynecologists who are coming. Because I had an very bad experience that a new pediatrician came. He was working since last 5 years at Himmatnagar. He got trained one of the best institute, and when he came to my place, when I was doing outlet forceps, he doesn't know what I'm going to do with this child. उसने कभी देखा ही नहीं था outlet forceps in his whole career. So sometimes just prolonged second stage of labor, we can use these instrumental deliveries very easily, and we must in institute we also promote these instrumental deliveries. What is your take on message, Dr. Atul Munshi sir? Am I right?
Yeah, you are right. I am also given today also do it outlet forceps, even vacuum and everything, because it is very difficult to deliver a cesarean section baby at the beginning of the third stage. It is always safer and do it. You have to wait for some time and then do it. As you said, a watchful expectancy till the fully dilated cervix is there. Head is quite low down, second or third. Then you can always apply outlet forceps. It is always safe.
I think Sir Kazi is right because Madam, I had put up a survey a few days back, driven by Dr. Harish Doshi sir. And to my astonishment, many of the people did not want to apply forceps rather than go to a cesarean section. So I think we have to revisit the lost art of instrumental delivery. Though I wouldn't be very heroic in going for mid cavity and everything nowadays, but still at least outlet forceps is something I think, Sarfaraz, we all should be knowing it. And that is, and when too, so I think we all are applying only, and sometimes it comes to a very good rescue with the silicone cups available. I think we all are happy to have it in our labor rooms. And the only thing is that we need to counsel and we have to explain the labor probably firsthand, though the days are back where we have to have a kangaroo mother care room, postnatal care, but antenatal, before she goes into the intrapartum, we have to be a counseling room where the labor pictures, what she's supposed to do and what we are supposed to counsel is very, very important, that how the labor goes and how the things progress. Because with Google Baba, they have got so many videos, lucrative, Dharavnes.
Yes.
So there are so many things that is bothering her mind when she reaches the labor room. The one thing is that, sir, you will agree that respectful motherhood is something what we all are aiming towards it. So I would also highlight one thing, that respectful intrapartum care is very, very important. Please do cover the patient properly and give her the privacy, whether we are a male doctor or a female doctor, that doesn't matter. But in the labor, sometimes we just forget, just drag the baby out, and we have to remember that everything is going into her head. She is not forgetting a single thing.
You rightly mentioned about this. This is a very important part of the thing because she will remember it for a lifetime.
So I think that is the joyful thing. And every time when the patient is into the labor, I take out time in spite of the anxiety. Sometimes we are anxious, the baby is not coming out. What will happen? We need to be very, tender, loving care. You are doing good. Motivate the mother to practice, because she has to be told that she's actually doing very good and the baby is progressing very nicely. If she's motivated, having confidence in the environment, and probably a labor room colored in pink, having good baby photographs and a light music running, all these things can add on to the joyful intrapartum care. And in that, I'm very thankful to be a part of this program. Dr. Meenu ma'am, giving me the proud to be obstetrician feel right now is something, a different feel which I'm carrying right now over here. With all, obviously, Charu here, Vaishu here, Reshmi, Meenakshi ma'am, Sarfaraz, Dinesh sir, and Dr. Atul Munshi sir. Thank you for giving me this opportunity. I wish you all the best for the West Zone BP, and similarly appeal for my votes also for the Midlife Management Committee. With my dear friend Charu here, I'm still so much part of the best committee. I cannot forget that beautiful time we have.
Excellent talk.
Very nice.
Excellent. Both the talks were excellent. And all the best to all of you. Thank you.
Thank you, sir.
Archana, this year our POGS logo was respectful motherhood.
Oh, wow.
Yeah, the similar thing what you talked. I still remember when I was doing internship, I was in the government medical college, government hospital in Chandigarh. And before the HOD would come for the rounds, they would ask every woman to, they wear salwars. So remove one part of the salwar and the underwear and just lie like that, because she had to see the episiotomy of all. So they would come with a torch, the nurse will be carrying the torch and just 1, 2, 3, 4, because it was like packed. So that scene, somewhere it is still ingrained in my mind. Ki aisa bhi ho sakta hai. How could that happen at that point of time? Now, of course, I'm sure the things must have changed there as well. But this is how busy labor room, busy, only 3 units, and each unit had like 100 deliveries in a month. So it was like huge load. Yeah. So right.
Sometimes to leave the patient is the best thing, because when I came to Gujarat in Vadodara, one day 30, 32 deliveries also. So we had babies everywhere, bed, labor room everywhere. But yes, respectful motherhood is something which is long stay and we should not forget. At least try to cope up, because our anxiety, our stress is there. But the female goes home with whatever memories we instill at that time. We all agree to that. Thank you for the opportunity, ma'am.
Thank you.
Best of luck, both of you.
Thank you, sir.
Best of luck to both of you. An excellent seminar. Thank you. Thank you.
Thank you, Dr. Dinesh, for joining. I just gave him a very little time to decide, but in spite of his busy practice, he did come to us. Thank you so much, sir.
No, we will be in touch, madam. Definitely, we are here for you.
Thank you, sir.
And Dinesh sir and Kazi sir, I will be bothering you for my nomination also.
No, madam. There is no option for you also. No? We are here for support the potential people.
Thank you, sir.
Under Meenu ma'am's head,
Okay,
the
madam.
GS was doing so superb. I mean, myself and Charu were discussing the other day at that time.
Thank you. Thank you, Dr. Archana.
Dr. Kazi is a very promising and very enthusiastic doctor from our Gujarat. Madam, he's going to make through very good in coming future. That is what I see, a very promising person in him.
I met him for the first time when I went for Sogog in Himmatnagar. And after that, we have been friends forever, you know.
Yes. He is actually a strong shoulder to me also. I just call him Kazi, ye karna hai, and like everything is done. That's so great of you, Dr. Kazi.
I am there always for both of
Yes,
you.
yes.
I will be there always.
Thank you so
And I always like to see Meenu ma'am with this spectacular
Adi
steps.
is a young potential person.
I love this combination always. And your smiling face, it's like
Thank you, sir. Thank you very much.
best of luck again, ma'am.
Aarti ma'am, you're on mute. You wanted to say something, but we couldn't hear it.
Bino is wearing blue spectacles.
Yes.
New one. New shade.
The cat's eye one.
Yeah.
So
And nice to see all of you, Dr. Charu ma'am, Dr. Vaisali. Dr. Vaisali also met there in Amox.
Amox. Yes, sir. Yes, sir. So it was wonderful listening to both our speakers, excellent talks. Meenu madam, every time you are just simply amazing and we learn new and new things. And Dr. Archana, your talk was superb. Like you said, you know, let it be a joyful experience for her also, for the patient, like the joy we get out of delivering her. For her also, it should be a beautiful experience. So wonderful talks and all the best to Dr. Meenu and Dr. Charu, and best wishes. So I would like to propose a vote of thanks to all the present here, all the delegates who have joined in, and from Pune, Baroda, Himmatnagar, all over India. And for
I think Subhash.
Dr. Subhash sir has joined.
Subhash has joined.
Give him 2 minutes to talk before we give.
Dr. Subhash has joined.
Subhash is here.
Welcome, Dr. Subhash Malya. He is a guest of honor. Charu, are you there? Would you like to introduce Dr.
Charu is there. Charu is there. Hi, Subhash.
I'm introducing you for so many times till now.
Please unmute, sir. Please unmute yourself.
Sorry about it, ma'am. Sorry about it. I mean, I'm in a case. That's why, ma'am. Anyway, I wish the whole webinar the best of wish. And sorry, ma'am. Sorry, Meenu ma'am and Charu ma'am for this. And I wish the program the very best of it. Thank you, ma'am. Thanks a lot. Thanks.
Thank you for joining in spite of your busy schedule. And we just have to, talk about you as our 2 a.m. friend. Whenever anybody in Foxy or out of Foxy is in need of help, we have to go to Subhash Malya. And he's really fantastic. And currently the chairperson of the endoscopy committee. Thank you, Dr. Subhash, for joining.
He is also a very good mimicry artist. I don't know if you have seen him or heard him. He can copy anyone like this. Subhash, are you there still?
Madam, we have got a very good experience. We had booked a PVR for 3D laparoscopy. So he was a co-host with us. So we had all the mimicry of everybody out there. But he's a very cute guest of honor, I would say. Doesn't look his age also. Subhash, you are there. We all are praising. All the ladies are praising you. Enjoy the moment if you're there.
I think he's busy operating.
Yes.
Yeah.
So I'm blessing them.
He's there to listen good things.
I'm blessing with all the good words that people have spoken about me. Thank you, ma'am. Thanks a lot. Thanks.
Yeah. So I would like to thank our President POJs, Dr. Aarti, Dr. Meenakshi, our General Secretary, Meenu Madam, Charu, Madhura, Chief Guest, Dr. Atul Munshi. Sir, it was wonderful to hear words of wisdom from you. Guest of honor, Dr. Subhash, who joined us and spoke with us, lightened up the atmosphere. And Dr. Rashmi Banerjee, Secretary Baroda, Dr. Meenakshi Patel, past President Sogog, and Dr. Archana, who gave such a fantastic talk. Dr. Sarfaraz Kazi, so wonderful to reconnect with you. Dr. Dinesh Patel, sir, such a wonderful experience we have learned from you today. Wonderful things, interesting things you spoke to us. And thank you to each and every one of you. And thank you, BSV, Mr. Prasad, for organizing the entire webinar. Truly a lovely evening of learning, academics, and getting together. And wish you all the best. Thank you.
Thank you, Vaishali. Thank you so much. Bye bye. Signing off for now. Thank you, Kazi. Thank you, Dr. Dinesh.
Bye bye. See you again, everyone.
Yeah, thank you, Mr. Prasad, for all the
Thank you, ma'am.
calls I missed. Sorry for that. Thank you.
Thank you.
Bye bye, everybody. Right and left shoulder.
Thank you. Bye-bye.
Bye. Bye.